Dr. Verenga, if you can please start your presentation.
Good morning, everyone. Thank you so much, Dr. Tosayo. I will start the presentation. Today, I'll be presenting on the topic EPAU means fetal medicine unit. EPAU means early pregnancy assessment unit. That's what EPAU means. We launched this week at Salem Gabe. The trainings are ongoing. What should I be doing here? Because I'm not sure. May somebody please admit people in the waiting room? It's popping on my screen. So EPAU meets fetal medicine unit. This is more of a conscientizing meeting for fetal medicine unit teams, so that people are aware of the EPAU and how they relate to EPAU as fetal medicine. Fetal medicine and early pregnancy assessment unit, they are there to complement each other, or they are there to improve the care of the pregnancy. The early pregnancy unit, what are the roles? This early pregnancy assessment unit, the first one has been launched at Salem Gabe, and I think another one will be launched at Verenga either next week or in 2 weeks from now. We need to understand what is the role of the early pregnancy assessment unit, and how are we going to be interacting with the early pregnancy assessment unit so that our roles do not overlap. My slides are refusing to move easily. So what are the roles of an early pregnancy assessment unit? It is there to assess all early pregnancy complications. When you are saying early pregnancy complications, we're looking at those complications that occur in pregnancy before viability. That is miscarriages, ectopic pregnancy, molar pregnancy, and any ailments that or complaints that women may have during the early pregnancy. It is also there to speed up management of early pregnancy complications. What has been happening it's still happening, right? Because early pregnancy is not it really started full operationalization. What is happening at the moment is that when a woman presents with acute pregnancy complications like bleeding or acute pelvic pain, what is happening when they are seen in our gynecological emergencies, they are referred for an ultrasound scan outside the unit, outside the hospital. And this is a result in women taking a very long time to receive care, so that a woman with a simple miscarriage can take 7 to 8 hours or even 24 hours for people to reach a diagnosis. Because most of the patients that we serve in our hospital, especially at Salem Gabe, the women of low socioeconomic status, some of them won't be having the money for the scan, so they will have to go back home and begin to scrounge for the money for the scan. I'm not sure how much it costs, maybe 30 US or so. And then they'll go for scan and come back. By the time they come back, most of them, they've bled too much, so that they will, on top of that, need a transfusion. Some have even lost their lives. Some are in care. This happens even to women who come with symptoms that are suggestive of ectopic ultrasound scan, and most of them have ruptured there. Some have died due to the delay in care. So the early pregnancy assessment unit will be there to speed up the management, to reduce them for one of the most critical roles that the Sorry, I lost connection. I'm back. So this is one of the critical roles that early pregnancy assessment unit is going to play in the care of pregnant women. The early pregnancy assessment unit will also be offering counseling services to women with the early pregnancy complications, and it will also be there to reassure women. Most women, they will, I think there's someone whose mic is not muted. There are a lot of echo feedbacks. Apparently there's none, so I don't know where they are coming from. So, it's there to reassure the women. Every woman who bleeds in early pregnancy is extremely, extremely worried about the bleeding. You will see at some point another presentation will be done today between 12 and 1. You will see that from studies done elsewhere, more than 50% of women who present to the early pregnancy assessment unit will actually be having a viable pregnancy, which is more likely to go all the way to term. So one of the things that early pregnancy assessment unit is going to do is to reassure those women who come with niggling things, some who come with minor bleed, some who come with threatened miscarriages, some who come with absolutely nothing except that they've experienced pain or they've seen something. It will be there to reassure the women as well, because women get extremely worried if they think they are losing their pregnancy. Sorry, the movement. Okay, yeah. Right. So, how is it going to work? Our patients going to be triaged when they go in the room. So when patients who are called here at Salim Gabe, patients who are referred from the casualty to room 20 to get gynecological consult, there are two categories of patients that we see there. There are those patients who have a chronic presentation and those who have an acute presentation. Chronic presentation in most cases is chronic pelvic pain. Of course, there will be some women who may present with chronic PV loss or PV bleeding. There are women like this who will tell you that have been bleeding for a very long time. These patients will be assessed by the cover team and they'll be referred. Of course, they'll be evaluated whether they need to be admitted or to be referred or to be reviewed in the gynecological or outpatient department. I'm happy that the clinics are returning. So they will be referred to one of these routes. The either admission, if their condition is critical. If it is not critical, then they will be referred to the outpatient department of gynecological outpatient department for their next review. Then we have patients who are bleeding, PV bleeding. I'm sorry, this moved here. Those patients who have PV bleeding, these patients will need to be referred to the EPAU. So that means they need to be seen by the EPAU team. The team that is doing the cover in gynecological emergencies need to line up these patients so that the EPAU team can see these patients who are bleeding. Then we have patients who have acute pelvic pain. Again, they need to be seen by the EPAU team. So these patients will be the candidates for the EPAU. Patient who goes to the gynecological emergency necessarily need to be seen by the EPAU team. If somebody comes and they're experiencing pain secondary to the fibroids, they don't need to be seen by the EPAU team. If somebody's got cervical cancer, non-cervical cancer, they've come bleeding from the cervical cancer, they don't need to be seen by the EPAU team. Somebody who presents because they have a very they are now cachexic and having difficult breathing and so forth. They don't need to be chronic condition that is eventually referred to the gynecology emergency will need to be seen by the EPAU team. Then how does the EPAU team work? The EPAU team will be serviced by all the cadres that you see illustrated there. We are training 2 midwives, and we hope to train more so that we have a pool. The PNO fortunately has given us about 8 midwives. We have to train. So far, we are training 2 of them, who will be part of the team that will be doing the ultrasound. So we have managed to train 2. We are training 2 who probably will finish today. These midwives are being trained to do transvaginal assessment of early pregnancy. Then we are also training gynecologists. We have 3 gynecologists who are undergoing training.
Dr. Verenga, we've lost you there.
The EPAU team that will be managing cases in the early pregnancy assessment, who also be part of the team unit. Can you hear me now? Is it better?
Dr. Verenga, you are fading. You are coming and going, coming and going. Hello, can you hear me, Dr. Verenga?
Yeah, I think I'm back now. Okay. Can you hear me, Dr. Fachayo?
Yeah, now it's better.
Great. So let me continue. So then we currently do not have a counselor, but we hope to look for a counselor who has to be trained in early pregnancy complication counseling. This will be the team that will be servicing, the main team that will be servicing the EPAU. Of course, this team will have a complement of nurses, and we also have a complement of junior registrars and SRMOs who will be working with them. So that's the team that will be spearheading the EPAU. Every one of these team except the counselor will be skilled enough to do transvaginal scans to determine the status of the early pregnancy. So any one of them will be skilled enough to do transvaginal scans amongst them. Then to just illustrate the patient care pathway that will be taking place in the EPAU, when a patient comes to EPAU, the history and physical examination will be taken and they'll be recorded in OBS Gyne Plus application. OBS Gyne Plus application is an application customized for gynecological consult. It's like the Fetal, but this is customized for gynecological consult. So that the application that will be used in the EPAU units. Then the patient has to be done a pregnancy test. Every patient who comes to EPAU has to have a pregnancy test. Then if it is not done, if it is already done, then this fair enough. We are also planning to introduce RESA status testing if it is not known. For those who come bleeding, who want to know their RESA status, then a Pelvic ultrasound scan will be done. Currently, we are teaching them to do transvaginal, but however, a transvaginal with or without transabdominal scan can be done on the patient. Then the findings will be recorded in the OBS Gyne Plus application. Then the management planning will be done after that, whether it is a surgical intervention, whether it is surveillance, or rather referral to FMU or reassurance. So these are the possible care pathways that will come. Of course, surgical intervention may include admission into hospital. This is to just give you an example of the protocol for management of early pregnancy bleeding with a viable fetus. This is a scenario where a viable fetus is there. So if you are managing early pregnancy, the baby has come viable, but when you do the scan, you see that there's a subchorionic hematoma, which is fairly common for women who bleed in pregnancy. If the pregnancy is less than 12 weeks and the cervix is closed, we just give, we manage it as threatened miscarriage, and we give progesterone 200 micrograms PV, and we can review again weekly in EPAU if the patient is hemodynamically stable. Then we have a scenario where the cervix is open. When the cervix is open, irrespective of the gestation, if it is in first trimester, not second trimester, first trimester, the cervix is open, we cancel patient on uterine evacuation versus expectant management. Then if the patient chooses expectant, we admit for observation and rescan after 48 hours. The reason why we are admitting these patients is because of the profile of our patients. If the cervix is open, and we know that the risk that this pregnancy is going to come out on its own, if we send this patient home, they may come out in a worse state than the one which they will have left the hospital in, and we might end up losing patients that we had a chance to save. So to avoid that, we will admit the patients who refuse to be evacuated. We have an open cervix, but the baby is still alive, because this situation do exist. This is a case of an inevitable miscarriage. So for these patients, that's the care pathway. Then greater than 12 weeks, whether the cervix is closed or open, and the fetus is viable, we want to give 200 micrograms and refer to fetal medicine unit for further assessment. The reason why we are saying we need to refer to fetal medicine unit in this case is that we know that there is always a room for rescue sacrilege in second trimester for pregnancy with an open cervix, and the patient need to be given that kind of an option. And we think the fetal medicine unit probably is best positioned to counsel these patients and to direct their care pathway. Well, this is a service offered under obstetrics, so it's better that this patient be managed in the fetal medicine unit than in the EPAU. So I'll repeat the last bullet again. We have a scenario, a viable fetus, of course, with subchorionic hematoma. If the pregnancy will be greater than 12 weeks and the cervix is closed, or even if it is open, the cervix, the baby is still viable, these patients will be prescribed progesterone and referred to fetal medicine unit, where further assessment will be done, including assessment of the baby's anatomy. Well, sometimes we may make effort to try and save a baby who is not, who has some defects not compatible with life. So it is important that these patients be referred to the fetal medicine unit so that the right things are done for them. Then we have a situation where there's early pregnancy bleeding with a viable fetus. I think this is just a duplication of the previous. Let me move on. Right, then we have a scenario where there's early pregnancy bleeding, non-viable. Let me go back to this. I think I left one bullet to say, if one of you in the fetal medicine unit bumps onto these patients here, these are not fetal medicine unit patients, you refer them to EPAU. There are patients who are going to come to fetal medicine unit who have wrong dates, who think they are advanced enough, and when you scan them, you find out that they are bleeding, but their pregnancy is less than 12 weeks. You refer them to EPAU, because in EPAU, that's where they are going to get their surveillance until they are 12 weeks, then they can be referred to the fetal medicine unit. That includes patients with miscarriages, patients with a threatened miscarriage, and those with an inevitable miscarriage. You refer these patients to early pregnancy assessment unit. You don't manage them in the fetal medicine unit. So all early pregnancy complications should be directed to the EPAU, to the early pregnancy assessment unit. Non-viable fetus scenario. So let's assume that the fetus is not viable. cervix is closed, hemodynamically stable, these patients can be given misoprostol 800 micrograms, both to evacuate and also to prepare the cervix for a possible evac if we don't succeed with the misoprostol. But these patients, we can safely review them weekly, depending on the gestation, of course. The EPAU specific protocols will be discussed somewhere else, but to just give you an overview to say these patients, once we do this, we need to review them weekly in the EPAU. We don't forget about them. We have to review them weekly in the EPAU and see how much has been expelled. Then we have a situation where the cervix is open, hemodynamically stable. Then we can cancel the patient on a uterine evacuation surgical versus medical management. If the medical management is chosen, then we have to give misoprostol and follow them up every 2 weeks. Then we have a situation where the patient is hemodynamically unstable. This case is better to do evacuation to make sure that we have arrested the bleeding so that the patient will not deteriorate. So in other words, patients who are hemodynamically unstable, the EPAU is not going to offer them options for medical management, but we have to intervene surgically so that we save the patient's life. Early pregnancy bleeding, pregnancy test positive. These are different scenarios that will come up. Pregnancy test is positive. Then we have a situation where there's a viable fetus, subchorionic hematoma, cervix closed. This is a threatened miscarriage. We give progesterone and we review the patient weekly in the EPAU. Then we have a situation number 2, viable fetus, cervix open, hemodynamically unstable, or stable, one of them, inevitable miscarriage. Then we go here, as I said the last time, that we can offer them medical versus expectant if they are hemodynamically stable, not unstable. Please take note of this. Then we have another scenario. Pointer. Let me look for a better pointer. Then we have another scenario: pregnant test positive, non-viable fetus, cervix closed. This is a missed miscarriage. Again, it follows this care pathway. Then the other scenario where we see echogenic material, no fetus, open cervix, incomplete miscarriage, we follow this pathway. Then we have a scenario where we will see a complex intrauterine echogenic intrauterine mass, no visible fetus. This is a molar pregnancy, and we want to do a quantitative serum beta CG and do suction curettage. Acute pelvic pain. Patients are going to present with the acute pelvic pain. If the pregnancy test is positive, then we have a viable intrauterine pregnancy, subchorionic hematoma, cervix closed. We manage this as a threatened miscarriage. Then we have a situation where the uterus is empty, or we see what we call a pseudogestational sac, or an adnexa mass, or an extra-uterine gestational sac, or a fluid in the pouch of Douglas. We manage as ectopic pregnancy. Then we also have another scenario where we have an intrauterine gestational sac which is viable, and a uterine adnexa enlargement with what appears to be a cyst is more likely to be a torsion of the ovary or a torsion of the ovarian cyst. So these are the different scenarios because the cyst may tort in pregnancy. So we shouldn't be forgetful of that. So I think this is a brief overview of EPAU. It is important that staff who work in fetal medicine fully understand the role of early pregnancy assessment unit, that we all are aware of which cases the early pregnancy assessment unit will manage, and we should also, of course, have an idea of how they are going to triage patients and manage them, so that when you see patients in the fetal medicine unit, you are fully aware that this is an EPAU patient, is not our patient. So patients who come with pregnancy complication under 12 weeks, they need to go to EPAU, or patients who come even after 12 weeks, but with an inevitable miscarriage, we refer them to EPAU. It is only those patients who are beyond 12 weeks who do not have an open cervix that they can still be followed up in fetal medicine so that they can be offered a stitch if the cervix open as part of rescue circulage, depending on their background history. I think this is the end of my talk on EPAU. I think I'll leave the room to questions. I'll hand over back to the chair, Dr. Hlachai. Thank you so much.
Thank you, Dr. Verenga, for that presentation. Can we please have questions now for Dr. Verenga on the early pregnancy assessment unit? Dr. Farai, please go ahead.
Good morning.
Good morning.
Mine is a question in terms of diagnosis. In early pregnancy, for example, within about 7-6 weeks, the placenta is not yet fully developed. And when you do a scan, how do you confirm that there's a subchorionic bleed? Would you see some fluid outside the gestational sac, or because the placenta is not yet clearly visible? So I just want to confirmation how to diagnose subchorionic bleed.
Yes, you are going to see, because when you do transvaginal scan at 6 weeks, the amnion is not yet well visualized. So what you are likely to see is just the chorionic cavity. What is referred to as the gestational sac is the chorionic cavity. So we are going to see that there is going to be another layer or an anechoic layer outside the chorionic cavity. But you need a transvaginal scan to be able to see this, because sometimes transabdominal scans will not have a good enough resolution. So you are going to see a layer of fluid or indenting into the chorionic cavity. There will be in an anechoic layer outside that gestational sac. That's a subchorionic bleed. Because what you are seeing, what you refer to as the gestational sac is actually the chorionic cavity at 6 weeks.
Oh, thank you.
Welcome, Jim.
Please feel free to ask your questions. You can raise your hands or you can type into the chat.
Where is the unit located?
Please go ahead and ask your question.
While they're asking questions,
hello, Dr.
Alfajak, let me answer the.
You're breaking. Are you talking to me to?
Hello, Sister Melody Nkomo had raised her hand, so I said she can go ahead and ask a question. In the meantime, as she's waiting.
Hello, thank you, Dr. Hlachai. I wanted to ask Dr. Verenga if there was inclusion of the pharmacists that to manage using progesterone, of which is very expensive for the government patients, or to buy it from the outside pharmacies. So I wanted to say, if there was a pharmacist, also to point out that this drug has to be available in government setup so that our patients can afford. Otherwise, it will be something else. All right, thank you. Hope you heard me.
Yes, I think we heard you loud and clear. I think the main question is you are saying that the progesterone currently is available only in private, so it's very expensive for our patients. How can we facilitate that the government sector also has it? I think that's your question, Dr. Verenga, if you can answer.
Thank you so much, Sister Chinama. That's a very important question. One thing which I want us to understand is that it's not like there is someone somewhere who is solely responsible for what the hospital should order or should not order. What the hospital orders depends on the vote of the doctors who are prescribing. There are some very expensive medications that can be found in Salim Mugabe or Parenyatwa who are more expensive than progesterone because the doctors who use those drugs, they've gone there and they've said, we want this drug for our patients. So the availability or non-availability of progesterone will depend on the EPAU lead clinicians to say how much noise can they go and make at the pharmacist's door, because the pharmacist has to order what we use or what we prescribe. So it is possible for progesterone to be available at Sali and Parenyatwa, but we just need enough advocacy because the pharmacist cannot just order his own drugs. He doesn't prescribe, but it is us who prescribe, who go there and tell the pharmacist that, look, we are going to be prescribing a lot of this drug. We want it. So it is possible, Sister Chinama, but things come through advocacy, especially at the level of the doctors. Doctors need to speak more and to demand more from their supporting colleagues like pharmacy and so forth. So it is possible. Then the next question is there, and where is this unit? This unit, we said it's being pioneered at Salim Mugabe. We started this week, but we hope to have another one at Parenyatwa maybe in 1 or 2 weeks' time. There is a team at Parenyatwa led by Dr. Madzire there who wants to run the unit. So we will be doing trainings at Parenyatwa in a very short space of time. But for now, it's at room 20, Salim Mugabe Hospital. I think there's another question again. Dr. Lasha, can I just go through these questions on the chat?
Yes, please, Dr. Verenga.
Okay, where is the unit located? We've answered that. For women with a viable fetus and an open cervix, if you offer them a vaccine, are we going to address the ethical issue that may arise in the future? You are right. That's a valid question. If you look at how we paraphrase the issue is that when a woman has an open cervix, it's called an inevitable miscarriage. How do we manage an inevitable miscarriage? An inevitable miscarriage, that we're talking of first trimester here. You will have to be very clear. Somebody comes at 8 weeks, the cervix is open, the fetus is still there. So what we do with these patients is we counsel them. We let them know what is their chance that the baby is going to miscarry anyway, because if the cervix is open at 8 weeks, 10 weeks, 11 weeks, honestly, it's going to miscarry anyway. So they may choose to say, look, let me take my chances and wait for the natural to happen. Or look, I do accept the risk and also I accept that my odds are now very poor. Please go ahead and evacuate the uterus so that I can start again. Today's management of patients is never prescriptive. A modern doctor does not prescribe what a patient should do. You tell patients the options, you tell them the risks, the odds of their condition so that they choose. This is why we say we offer them expectant versus evacuation. So it is not us who make this decision. It is the patient who makes their own decision after we have given the patient adequate information. This is very important. No doctor tells the patients what to do. You don't tell your patient what to do. You tell them the information, then they will give you a permission to say, after I've understood what you have said, doc, can you please go ahead and do A or B? And all you do is to support their decision. So I hope I'm addressing the ethical dilemma, but inevitable miscarriage,
This is how it is managed everywhere. You don't make the decision, but you told the patient that, look, the service is already open. It is up to you to say, do you want us to go ahead and help the situation, or you want us to wait for the natural to happen? I hope I've answered you successfully there.
Yes, Dr. Verenga, thank you.
Okay.
There are no more questions in the chat. If there's anyone else who wants to ask any question, you can go ahead.
Maybe to comment that the EPAU in Salumgabe, Dr. Lachayo, will be led by Dr. Makore and assisted with Dr. Chamunyonga, so that if colleagues want to conduct the lead person for the EPAU, you should know that Dr. Makore will be leading, assisted with Dr. Chamunyonga to run the EPAU here. But there is a big team which they will be working with as well.
Okay, thank you for that information, Dr. Verenga. There's something which I need clarification on. Earlier when you were presenting, I might have missed this information. You initially said if the patient has an open cervix and they're below 12 weeks, they should be managed in the EPAU unit. And then afterwards, you said if they are more than 12 weeks, initially I think you had said they should be managed in the, they should be referred still to FMU because of issues to do with rescue sacrilege. Then later on, I think you changed, you said they have to go back to EPAU. I might have missed that information. I don't know if you can go back on that.
I think, is it this slide, or let me see which slide that pertains to. Right, so let me start with this slide to say we have a patient who comes, viable fetus with subchorionic hematoma. As long as they are below 12 weeks, these are EPAU patients. The EPAU has to follow them up until they are 12 weeks. When they are more than 12 weeks, they have to be referred to the FMU. Why are they being referred to the FMU? They are being referred to FMU so that one, FMU can do a thorough check on this baby to say this baby who is threatening to miscarry, is it a morphologically normal baby? Are there features of chromosome abnormality? Because we could be putting a lot of effort on a baby who is destined to miscarry because this baby is severe morphological malformations and probably has features suggestive of chromosome abnormalities or genetic syndromes. We know that this skill for now rests in the fetal medicine unit. Probably a time will come in the future as people get more and more deep in their skills that EPA will be able to assess these patients to the level of fetal medicine so that they may not need to refer them. But one of the other reasons to refer is so that we can screen for aneuploidy as well for these babies at 12 weeks. Because we want to see all pregnancies at 12 weeks, not only to screen for aneuploidy, but to screen for other pregnancy risk factors like preeclampsia as well. So this is why they have to be referred. As long as the service is closed, we are saying this is a pregnant that can go on and be okay. You will see when my colleagues presented probably in the afternoon that for the women who come with bleeding first trimester, from the case audits from the units that have been running, because EPAUs have been in existence for 30 years, because they started in 1991 in England, early pregnancy assessment units. They've been there for 30 years now, and people have published their case series, and from those case series, we know that of the women who come bleeding, 25%, unfortunately, they will end up losing their pregnancy, but 75%, those pregnancies will go on to be viable. This is what we know from those case series of women who present to EPAU with PV bleeding, with threatening to miscarry. 25% will go on to have a miscarriage, then the rest, 75%, about 75% will go on to have a normal pregnancy. So that's the reason for referring to, they have to go to EPAU for the 12-week assessment. But I said for women, even those with an open cervix, they still have to be referred to, if they're above 12, to be referred to fetal medicine unit for fetal assessment. Why? Because the fetus could be morphologically grossly normal, and we need to cancel the women probably to allow termination to occur. Because currently this skill to do this race in the fetal medicine unit, to properly assess the baby who is threatening to come out, and also to be offered the chance of a rescue cyclage as well, if they are beyond 12 weeks. Then the ones which I said, they can be managed in the EPAU. We said if we see a patient who is beyond 12 weeks, who is probably miscarrying, who is in the category of a miscarriage, those patients will go to EPAU. We don't manage them in the fetal medicine unit. You have seen a patient, the baby is dead, cervix open or closed, they are below 20 weeks, they go to EPAU because our antenatal doesn't manage babies who are below 20 weeks, right? Should be 20 weeks, yeah. Is it 20 weeks or 24? It should be 20 weeks. These are EPAU candidates. But all patients above 12 weeks have to pass through the fetal medicine unit for fetal assessment. Did I make myself clear, Dr. Lacha, or you are still?
Yes, no, I think it's not clear to me. Whoever is 12 weeks and above will have an assessment by FMU. Why? Because we want to rule out chromosomal abnormalities, that congenital abnormalities, and then later on, depending on what we find, I think then we can map a way forward, isn't it?
Yeah, you're right. You're right.
Okay, thank you.
I don't see charts in the on the question. I don't know if we're finished, Dr. Tachayo.
I don't know if we've exhausted all our questions so that we can end the meeting. Okay, I know it's just a comment. Congratulations from Chipo Gwanzura. I think since there are no more questions, we're going to end the meeting. But we want to thank you, Dr. Verenga, for this initiative to start EPAU. It's long overdue in this country, and hopefully Paranato will be able to also set up its unit in a week or two, as you say. Thank you all. Thank you for joining the meeting. We look forward to seeing you again next week for the Friday morning meeting. Thank you all.
Thank you. Just some few announcements, Dr. Tachayo. Sorry about that. I wanted to say my EPAU colleagues will be presenting this afternoon at 12 to 1 during the UZ Department Unit of Obstetrics meeting. So please tune in. They will be presenting more detail. They will be presenting the evidence that support the EPAU, that they will also be presenting things like acceptability, because there are people out there who believe Zimbabwean women do not accept transvaginal assessment. My colleagues will be answering those kind of questions, those kind of pessimistic views. So please tune in at 12, and they'll also do some live demonstrations of scanning pregnancy complications. So please tune in at 12, and you will enjoy the presentation from my colleagues in the EPAU. Then the last thing is that I think we gave each other tasks for research to just do the literature reviews of the topics we have. May we kindly submit those over the weekend or Sunday. If they are not submitted, we consider them not done. We'll take over the project and do it. So please, by Sunday, let's make sure we submit what we volunteered to do. Thank you so much. Bye-bye.
Okay, thank you, Dr. Verenga. Bye.